afternoon. I'm so glad everybody's talking. And, do we have our recording on? Yeah. Okay. That's a good sign. I like all the conversations. People are getting comfortable. There's lots of great ideas floating and energy, and that's just wonderful. So we're going to start the afternoon with our panel on health policy. And I'm just going to introduce the moderator, Michael Parchman. He's a family doctor at Group Health and director of the MacColl Center. He came to us recently, about a year ago, from the Agency for Healthcare Quality Research, I believe, ARC. And there he directed a program on practice-based research networks. What that means is doing research in community practices, mostly centered on quality improvement. So he's an expert in that area, and he's carrying on his work now through the MacColl Center for Healthcare Innovation. We're very lucky to have him here to share his expertise with us and moderate this panel. Thank you.
Thank you, Lou. Well, buenas tardes. Bienvenidos, Seattle. Spanish is not my first language, if you can't tell. It's a real pleasure to be here and to network with all of you. I had a hard time dragging myself into the room just now because I was out talking with someone else about another exciting potential project. So thank you all for attending our meeting, and it's a thrill to be here. It's my job to introduce our panelists, and then to get out of the way. So I'll do my best to do that. So let me introduce our panelists for the afternoon. Join the conversation on Twitter. Okay. Pound Latino Health. Okay. All right. I'll try that. So our panel this afternoon is they're tasked with addressing the issue of health policy around Latino health. And I'm just going to introduce people in the order in which they're presented in your program. So first we have Mayra Alvarez. Mayra is the Associate Director for the Office of Minority Health at the U.S. Department of Health and Human Services. She's worked on help coordinating that office's work related to the Affordable Care Act, but also helps with coordinating work around community health workers and promotores de salud. The second panelist is Federico Cruz-Uribe. Most recently, he was director of the Tacoma-Pierce County Health Department here in the state of Washington for almost 15 years. And he's also currently the Vice President of Clinical Affairs for CMAR Community Health Centers based in Seattle. And just a personal note, he and his wife established and ran a diabetes control project in southern Nicaragua, which is where my wife is from. So another connection. And then Sam Byrd. Sam and I had the privilege of visiting over lunch today. Sam is the director of Centro de Comunidad y Justicia, which is a nonprofit community-based organization in Idaho, working at social, educational, and economic justice for Latinos. And he's been the recipient of numerous awards, including the Distinguished Leadership in Human Rights Award by Hewlett-Packard. And last but not least, Maria Benavides. Maria is the Director of Outreach for the Yakima Valley Farm Workers Clinic. She's been working for over 20 years in that setting. As many of you know who do that work, she has developed vast knowledge in terms of what it takes to collaborate among community agencies, school districts, community resources, institutes of higher education. She is one of these boundary spanners that puts things together and figures out how to solve problems. So we're really thankful that she is here too. So I think we're gonna have each of you talk for a few minutes. Is that right? Do a short little presentation, all right? And then we'll do our panel discussion. So, Mayra, you're up first. Do you need anything?
No, I'm good.
Okay.
Very low-key.
Me too.
Great. Good afternoon, everyone. Buenas tardes. I'd like to start by saying thank you to the Planning Committee for the invitation to be with you all today, but also for the tremendous work you're doing to improve the health and well-being of the Latino community with the inauguration of the Center for Latino Health. Congratulations to you. A special thank you and acknowledgement of my colleague, Jesus Reina, for his leadership here in the regional office on behalf of the Office of Minority Health. There he is, that's right. Our regional offices are critical to the work we do in DC and really are our eyes and ears on the ground to inform us of our process moving forward in the central office and make sure that we are reflecting the needs of the communities we intend to serve. I'm really excited to be here with you. It's a really key time for the work that all of us are centered on. First and foremost, it's April. It's Minority Health Month. And for those of you that do not know, this year's theme is Prevention is Power, taking action for health equity. And I think there's no clearer area where prevention is so powerful than in the health of the Latino community. When you look at chronic diseases that impact the health of our community, oftentimes they're preventable if people actually go to the doctor and are able to seek preventive services or lead healthier lives and eat well and exercise. So as we consider what we are doing in April and throughout the entire year to improve minority health and improve health equity, prevention is key to that discussion. And I know it will be key to the discussion moving forward for the Center for Latino Health. But I also think it's an opportune time to talk about the health and well-being of the Latino community because we are celebrating the 50th anniversary of the Civil Rights Act. And when you consider health and the power of having healthcare access and looking at health as a right, it really is considered, the next civil rights issue of our time, access to healthcare and ensuring that every person has the opportunity to reach their full potential. At the Office of Minority Health, we focus on 3 strategic priorities related to ensuring our communities can reach their full potential. The first is supporting implementation of the first ever HHS Disparities Action Plan. And I think it's important to highlight that we have an action plan because it's something that the Secretary has been committed to from the beginning and that as a department, we've been able to really prioritize across the board. At the Office of Minority Health, we live and breathe health equity and opportunities to improve health equity. But we also recognize that we're a very small office and much of the work to improve health equity must be integrated in all of our agencies at the Department of Health and Human Services. And this action plan allows us to hold our agencies accountable to goals that we're setting to reduce health disparities in the future. We also support the National Partnership for Action and the Elimination of Health Disparities through the coordination of partners, leaders, and stakeholders committed to this work across the country. The National Partnership for Action, or NPA, allows us to integrate our community members in the work that we do at the federal level, again, to ensure we're being responsive. And then finally, our third priority is supporting the implementation of the Affordable Care Act, and in particular, its impact on the health of racial and ethnic minority populations. Through these priorities, I think it's clear that we share in the work of the Center for Latino Health and your future work to foster the health and well-being of Latinos in Washington State, regionally and nationally, but also for all communities of color through our policies and programs that are aimed at reducing disparities in health. I think in the simplest terms, we fight for the goal that's at the heart of the American dream. That's equal opportunity for all people, no matter their background or their heritage. And I think it's clear that you can't have opportunity without good health. If you consider our goals as a nation, whether that's helping kids succeed in school, creating jobs for people, building stronger communities, health is connected to every single one of those goals. And on an individual level, health is fundamental to opportunity. A child who isn't protected against the measles or chickenpox is going to miss class and fall behind their peers. A mother who has unmanaged diabetes is not going to be able to work a full work week and therefore not be able to take care of her family. Time after time, when we're talking about some of the most basic problems in our society, health has a contribution to ensuring that those problems are solved. Young people, in particular, if you have a stack of unpaid medical bills, it's going to be very difficult to fulfill or pursue your dreams. If we want to give every Latino, every American a chance to reach their full potential, we need to start with improving health. And one of the single best steps we can do to make that happen is address health disparities. And that's why right now it's an exciting time for our country. About an hour ago, the president announced that through the Affordable Care Act, 8 million people have signed up for coverage through the health insurance marketplace. That's on top of the 3 million people we've enrolled in coverage through Medicaid and CHIP. That's on top of the 3 million young adults that have been able to stay on their parents' plan until the age of 26. That's up to about 1 million young Latino young adults. It's really a key opportunity to ensure that access to coverage, quality, affordable coverage, is a reality for millions of Americans across the country. And on top of access to care and coverage, there are several real new benefits for folks across the board that already had health insurance. No one ever being denied because they have a pre-existing condition. Women never charged more just because they were women. People not having to worry that if they get sick, they're going to brush up against a lifetime limit and not have the safety and security that health insurance was supposed to provide. People who lose a job, not worrying that they're not going to be able to afford COBRA and lose health insurance because they'll have a real safety net to fall back on. These accomplishments, the 8 million people that are enrolled, the millions more that are on Medicaid and CHIP, the real consumer protections that we have, they're shared accomplishments by the federal government and many, many, many national, state, and local organizations that have been with us in trying to enroll people in coverage from the beginning. I think from the beginning, the federal government that knew we were not going to be able to do this work alone. It's why we've been grateful for the support and partnership of national organizations and state and local partners like community health centers, libraries, job centers that have really taken on health as their own issue and integrated into their programs. At the Office of Minority Health and at every agency at HHS, it's truly been a multi-pronged approach at trying to enroll people in coverage. So it was having our administration officials travel to different towns. It's utilizing Spanish language media, a trusted resource in the Latino community, to integrate messaging into their programs and into their shows throughout the day. With partners in the faith community, it's allowing our leaders in the faith community to hold community events and ensure that they're going where the people are at. We've utilized social media. We've done Google Hangouts and Twitter chats and blogs and emails to a population that we know is disproportionately more likely to have some form of social media activity, whether that's Facebook or Twitter. Latinos will have that cell phone and be able to utilize that as a medium of communication. And I think most importantly is the partnering on the ground, going to where communities are at. We've helped to host enrollment summits in communities that need to hear the message the most. They were often held on Saturdays. They were often the work of many public health advocates that have been doing this work for decades. And it's something that we've seen as most successful in actually enrolling people in coverage. I think this highlights a theme that's run throughout today's presentation, and that's really the importance of community and engaging community in the work we're doing as either healthcare policy officials or program officials trying to address health disparities. And I think now, as we look forward to the next open enrollment period and these next 7 months as to the newly insured, we really are focusing our attention to trying to figure out what are those lessons learned? What are the best practices that worked in enrolling Latinos in health insurance? We have yet to announce how many Latinos actually enrolled. Out of that 8 million people, how many are Latinos? We're trying to actually scrub the numbers now and see what that data looks like. But I can tell you it's not going to be the 10.2 million that were eligible. Why not? What stopped us? What were our challenges? And what did work to enroll the people that we did? Was it our community fairs? Was it Spanish language television? Was it a mother having enrolled and getting her kids? We need to identify what those strategies are so that we can then redouble our efforts, target more effectively our resources for the future. So as we consider the importance of the Affordable Care Act, I think it's important to keep in mind that it's not only that coverage, but also access to care. So as we transition into these next 7 months, it's making sure that the newly insured know what they're doing now that they have that insurance card. And in particular, prevention and ensuring that they can access preventive services that are right for them depending on their age and depending on their gender. So I think it's an important conversation and something that we've really embarked on called Coverage to Care, which is how do you pick a provider? What services do you need? What about a deductible? What's a copay? Really explaining these concepts and utilizing the tremendous network of community partners that were already on board to do so. So I think moving forward, we want to ensure that the security and peace of mind that comes with health insurance is extended to the 10 million that are eligible. And we've got a ways to go. We know that almost 1 in 4 of the eligible uninsured are from the Latino community. We know that about half are between the ages of 18 and 35. The majority, almost 2/3, live in California, Texas, and Florida. And the reality is, when we're talking about opportunities to expand coverage, we need to talk about Medicaid. And we need to talk about the fact that these states are choosing not to expand coverage of Medicaid to some of the millions of the most vulnerable. We expect that 5 million people will be left in a coverage gap, without an opportunity to access quality, affordable coverage. And disproportionately, that's people of color. So how do we continue to educate our community members, our elected officials, about the importance of Medicaid? And I think, slowly but surely, it's making a difference. I think if you look at states across the political spectrum, they're taking up the opportunity to expand Medicaid because it's not only a good financial deal, it's the right thing to do for the health and well-being of their communities. I'll close with this. The president made clear in his State of the Union that this year was going to be a year of action. He said that we're united as Americans by the belief we share in opportunity for all. The notion if you work hard and take responsibility, you can make it in this country. And it's happening. I think access to health insurance is one more tool that we can provide the Latino community to make opportunity a reality. The most telling evidence of the impact of the health insurance marketplace is not in the numbers enrolled or the dollars we're saving or the future dollars we'll save. It's the actual people that are getting health insurance and the security that it provides. It's Omar in Texas, or Elizabeth in New York, or Angel in Los Angeles, or my little sister, Alejandra, who, because of the Affordable Care Act and the expansion of Medicaid, she's 21 years old and is on Medi-Cal. And I can tell you she does not know what she wants to do with her life, but I can tell you she's a little bit more secure, knowing that she has health insurance that's going to provide her in case something happens. So those personal stories are what are clear that the Affordable Care Act is working. Bottom line. For those people that already had coverage, your coverage is stronger and with better protections. For those that didn't, there was opportunities to access care at a quality level and at an affordable price. And for those of us who have known someone who was uninsured, who have loved someone who was uninsured or underinsured, it's really changing the ballgame for the future. My final thing I'll say is one of the quotes that I heard a lot from my mom as we were growing up in Spanish is, "Dime con quién andas y te digo quién eres." And I think that for the people in this room that are dedicated to the Center for Latino Health, we're in great company. And I'm looking forward to the work that you're going to do together and that we'll do together. Thank you.
So how do I advance in with this?
Yeah. Yep.
Greetings. I work at Seymour Community Health Center, and I want to chat just briefly about healthcare reform, the response of our community health center to it, and then I want to digress into something that's personal, lessons from abroad, because I've spent the last 5 years working in Nicaragua with my wife in a project. And I think it's very relevant to the realities we face every day as we try to serve people in the community health center setting. I think you've heard a few things other speakers have mentioned. My boss, Rogelio, talked about CMAR. I just have to preface a few things about CMAR. It started out as this little mom and pop outfit, one clinic, one provider, a couple staff, and some volunteers. And now it's a system. We have 89 sites in 11 counties. I said 10. We've grown. Roughly 250,000 people served last year. 150,000 unduplicated patients in our medical clinics. These are big numbers. The sea change that's happened to us recently through the Affordable Care Act is now we have 75,000 managed care patients in our system. And that represents a 50% change for us, which is a huge development, has tremendous implications for how we operate. CMAR as a system is committed, and our values are really straightforward. We are committed to being patient-centered. We've established medical homes. That means that each of our patients has a primary care provider. Each patient is assigned to a multidisciplinary care team. Each patient has a comprehensive health care plan. We're committed to providing comprehensive services. So yes, we provide primary care, acute and chronic care, behavioral health services, substance abuse services, inpatient substance abuse and mental health services, nursing home services, dental services. It goes on and on. We've really made a commitment to being as comprehensive as possible. We're also committed to being coordinated, and everyone talks about it. It's a huge struggle. Our healthcare system is very chaotic. We have silos everywhere, but we're committed to figuring out a way to link those silos together and have people work together in managing their patients. We're committed to being accessible. And traditionally what that meant was we had a building geographically located that made sense for our patients. And we've done that. We have a tremendous number of sites across 11 counties. But now it means, how can our patients more easily access us? It doesn't physically mean they go to a facility. So we're establishing a patient portal. We're doing texting and cell phone messaging. We're doing home visits. We're establishing more and more groups in the community that people can access much more easily. And then, of course, we're committed to excellence, so it literally means what we do is it's an iterative process. In other words, we set goals and we see if we've made any progress on those goals, and we change them if we change what we're doing if we're not making progress. And that's a huge commitment on our part, because we have to pay attention. Are we actually improving the health of our patients? Now, the two realities that I want to point out, we are seeing increasing patient loads, and the two phases of the Affordable Care Act. The first phase is frankly the easy phase, getting people enrolled, even though it's a lot of work, and we've spent a tremendous amount of resources doing that over the last year. Phase two is the hard part. Now that we've got them in the system and they've got insurance, how do we provide them the care they actually need? Which means we have to change the healthcare system. And that's what we're facing right now. What's pushing that, of course, are the financial drivers, because they are changing. As I mentioned before, we have 75,000 patients in our system. A little more than half of our patients are managed care. It means it's not a fee-for-service model. It's being driven by a global capitation. So what we had structured before was based on encounters. We got reimbursed when we saw people. Now it's, can we keep people healthy? We're focused on something. Now, we haven't made that full switch yet, but the drivers are saying to us, well, you're getting this amount of money for this patient. What are you going to do to keep them healthy? Our strategic response. Sometimes it seems like a madhouse where I work. It's very exciting, and I love it, and I thrive on that kind of chaotic, changing environment. And there's a lot going on. So we've focused on three big areas because we have an increased patient load coming in. We have a lot of complex patients coming into our system. How can we improve the efficiency of our existing care teams? That's a very big focus for us. And so we've approached that by empaneling. We've approached it by bolstering the support staff that we have for our providers in our clinics. We're looking at the use of scribes. We're trying to get our electronic healthcare record to be more user-friendly and actually be a work saver for our providers and staff. These are all huge undertakings, but I think they actually are making a dent in the efficiency that we handle patients. Secondly, we're trying to recruit. We're trying to add more providers to our system. And we are. It's a slow process, and everyone's in the same boat. So there's competition. It's not like there's this huge surplus of primary care providers in the United States. If anything, there's a shortage. And so we have to compete with the Providences of the world and the Multicares and the Franciscans, and that's a tough one. And on top of that, we have our sites, and some of our sites can add easily more staff to them. Others, we're at max capacity. So even if we had another provider, where would we put them and the support staff to go along with another provider? That's a big issue for us. Another issue that's come up that we're working on is, as we recruit providers, we're finding that we're hiring people with little experience. They're coming right out of their training programs. And how do we ramp them up? How do we prepare them for the realities of these huge caseloads that we're going to expect them to see? If you don't support them properly, guess what? They burn out and they quit. And it creates a huge trauma to our system and to our patients. And so that's something that we're working on very, very diligently. The third one is a new thing that we're focused on, and it's care management. And the goal is partly to shift the workload from this clinic-centric setting away from the care team out into other settings. And there's some obvious things that we can do. Of course, we are shifting to more group activities for our chronic disease patients, as an example. A huge number of our patients have behavioral health issues. We've added a tremendous number of behavioral health staff. We have actually more behavioral health staff providers than we do medical providers, which is, I had just added the numbers up the other day. I didn't realize between our substance abuse treatment people and our behavioral health treatment people, we have 150 providers in our system. We're risk stratifying, we're identifying our patients, risking them, and targeting the high utilizers. And that, again, we're attempting to take some of the workload off the care teams and interact with those patients in other settings. This involves just a blizzard of work, each of these areas, and so it's all happening at once, and it's just the reality that we face in the community health centers. Fortunately, we've learned over the years to be resourceful, and we're used to working in situations where there's this constant pressure and this constant change. Let me talk about something that's fun for me for just a few minutes. I don't have a lot of time. As I mentioned before, my wife and I had a chance to move to Nicaragua, and we ended up starting a diabetes control project. And one of the things, there were lessons learned. I just want to share a few things that I learned personally. My first example is, and I should call it the humility thing. I went down there, and whether I would admit it or not, deep in my heart, I thought I was an expert. So I knew that I had solutions for the healthcare problems on a local level. And one of the things involved, well, we're going to set up a clinic, and we're going to build a building, which we did. We located it centrally on the paved road there, and we didn't bother to ask our prospective patients, well, does this make any sense? And we built the building, and no one came. And it was like, well, why don't you come to our building? And then we asked people, and they said, oh, well, Federico, my road washes out 6 months of the year. It's too far. I can't afford the bus. And they had a myriad of reasons. And what they said was, why don't you come to our village and provide the services there? Duh. Okay. This is a really huge issue, and we deal with it every day in our clinics here in the United States, fatalism. When a patient's diagnosed with diabetes in Nicaragua, they felt like God had touched them. This was my fate. I can't do anything about it. It's not true. And that part of the dynamic of the clinical process down there was to create a can-do attitude. I can manage this disease. And that meant doing it in a group setting and using locals leading the group processes. Very powerful dynamic. Limited resources, we all face that. Just down there, it's so extreme. You learn to be incredibly resourceful and focus. Focus, focus, focus. Don't promise things you can't deliver. That was one of our patients at one of our clinics. He walked in right in the middle of the session. Leadership. Again, we had to overcome the notion that we had all the answers. And so it meant recruiting people from the local villages to run everything. Run the clinics, manage the groups, come up with the solutions. When people have questions, you answer them. You deal with it. And that was a very powerful dynamic. And lastly, and my favorite picture, it's about trust. People there became used to programs and providers coming and going. Medical missionaries, the government starts a project, 6 months later it's gone, that kind of thing. And they became very cynical and the trust levels were extremely low. Building trust means being dependable, offering quality service, and being compassionate. Enough said. Thank you.
You got it. Thank you. Good afternoon. Buenas tardes. I think part of the walk down here is kind of scary for those of you who haven't walked down here, right? That's the scariest part. I thought, well, I'm going to be nervous speaking. Nah. Walking down the stairs, So the nervios, not those kind, ¿verdad? Are gone. So my name is Sam Byrd. I'm the director of the Centro de Comunidad y Justicia, and I'm sorry for those of you who have to say that. And you're not used to saying it because it is a mouthful. We were founded, I was working for the State Board of Education in Boise in 1996 and 1997. Went to Mexico because I was very frustrated. I was trying to change the world in terms of, equity and education for Latinos in Idaho. And I went to Mexico and I had this epiphany. I gotta quit. It was extremely scientific, very well calculated, based on years of no. But, you come to a point in your life when you realize, I've got to make a change. And so, I told my boss, and she was quitting too, to go to the Albertsons Foundation. Albertsons Foundation in Idaho has put more money into public education than the legislature has. So yeah, well, I don't know if that's good or not, right? But the idea is that Trudy was going to go to work for the Albertsons Foundation, and so she was on her way as well. And so one of the things that happened was, she says, what you ought to do is you ought to start an organization. Are you crazy? It's like, and she says, yeah, start an organization. You ought to focus just on Latino issues and education. And I thought, she's crazy. About 30 minutes later, I walked across the street to the Secretary of State's office after having downloaded bylaws that we plagiarized off the internet, and we just put in, we came up with a Council on Hispanic Education. It resonated with folks who spoke English. But the community who spoke Spanish were like, what? The council on what? So we went out, we organized parents, and the whole idea was that's how we were going to change schools, and we used the Freire model, Paulo Freire model of organizing, right? And very successful. Schools hated it, but the parents loved it, and we thought, wow, what's wrong with this? Must be going to work. And so, but when we started, they say, well, the parents would say to us, well, but you guys do immigration? No, we don't do immigration. We're trying to organize parents, importance of education. No, pero no tengo papeles, I don't have papers. Yeah, but we're organizing, doing education. Yeah, but I don't have papers. And I thought, man, don't you get it? So I went back to my board, right? Community-based board, right? Farm workers on there, other people, people from the community. How's it going? Well, I'm having this experience. I don't know quite what to do with it, I said, we keep saying we're here to organize parents around education. They keep asking about immigration. And all the board members go like this, which in Spanish means, oh no, right? Oh no, but oh yes, we know what we're going to tell you. Oh no, don't. So if we're asking them to do something because we think it's important, isn't it fair that we do what they ask us to do? And that changed everything about it. So we became Centro de Comunidad y Justicia. Yeah. So I came to Idaho as a migrant farm worker. I thought we were coming on summer vacation. I was 9 years old. I was rudely awakened in a sugar beet field in a place called Paul, Idaho. The signs: no dogs, no Jews, no Mexicans. were still up. And I thought, you got to be kidding me. So I knew what a dog was. I did not know what a Jew was. And I was really confused about what a Mexican was because I figured I am one. But you see, I have three grandparents in San Luis Potosí, one grandfather from Mississippi, Byrd, B-Y-R-D. So I would get it from both sides. You know, I'd say, oh, you're not Mexican. You have a last name of, how come your name's not Salinas, Fernandez? And I go, I don't know, dude. I mean, and then I say white people are actually pink, right? So the pink people would say, you're not white. And so I grew up early on, and so I have that predicament today. I'm following up, you know, someone from the administration's office, and I applaud you. I do. I applaud what you're doing and the effort that the president and you as a staff has undertaken. But, you know, I kind of feel like, you know, like some of those earlier experiences, and I have to stand up and I have to tell you that I come from a state where they haven't expanded Medicaid. And I have to tell you that I come from a state that, you know, it's not going to paint it as rosy as some of you are painting it, or as promising as it looks for CMAR in terms of what you're doing to prepare. So I apologize for that. But I'm saying this con mucho cariño. I don't know how to translate that because it loses something in the translation. But I say this with a lot of respect and with a lot of love for what you do. For people like you, really, is why I'm in front of you, you know, because I came out of the fields to basically learn how to do this work. So let me tell you, I support the president. I support the Affordable Care Act. But if my experience is any indication of what Latinos who don't speak English or who may not have been born in this country or who are not as fluent or literate, if you will, in systems, then we're in trouble. Because you see, I had no health insurance up until the ACA. Because those of us who work for small nonprofits, we too reflect many times. Rogelio, I'm sure you came from there. Many of you came from there. I work for large nonprofits. I've worked where there are a lot of benefits. But part of working for a small nonprofit also means that you too are part of basically where your population is, because I didn't have health insurance. And to try to navigate that system, with all due respect, con mucho cariño, it was one of the most difficult things that I've ever done. I did it on my cell phone, and at first I thought, oh, this is easy. So way to go there. But it's the navigating. It's the understanding. Even though you understand, even though I've been around this, even though I have coverage, I understand deductibles, I understand out-of-pocket, I understand all these different types of things, that how difficult it is, because we're speaking a different language. We're truly not speaking in English. and even if you translate it, it loses everything in the translation, because it's a concept that is foreign to many of the people that we represent. It's just not the lived reality. And so how do you get people to understand a program when they can't really grasp the concept? And nothing is free. Gavish? And so you tell somebody who's poor that something is free, it's like, okay. Like, what's next, right? You know, yeah, right. Yeah. So what's going to happen next? So in Idaho, we have 258,000 potential non-disabled adults who they're eligible for the Affordable Care Act. No undocumenteds, and there are restrictions in Idaho on folks who have recently become LPRs, legal permanent residents. So, you know, so you think you've arrived, you've gotten status. Of course, the deferred action, that's a whole other thing. For those of you who have been doing work in deferred action, this is a promising program for young people that attempts to get them really engaged and involved. And here comes the ACA, and of course they felt that this was something that they would be eligible for, and a lot of confusion, but a lot of disappointment, you know, because definitely there are young people who need it. There are in Idaho many Latino adults, and I say pink adults as well, who who fall into that coverage gap, and so they're earning too much, but not enough to qualify for the premium credits. Okay, so in Idaho, you're talking about 55,000, 91%. I believe it's the highest rate in the country in terms of the number of people who share of poor, uninsured adults that are in the gap, 91%. So because there's not a Medicaid expansion, then, you really have, a number of people who are not going to get served whatsoever. And so the problem is that you really have also the issue of blended families. Blended families did not sign up. Why? Well, because the parents are undocumented, and someone from Washington said 90% of the children are born here. Same is true in the other northwestern states and in many other states in the country. And so if the parents can't sign up, and in a state that has the non-Medicaid expansion, you've effectively excluded all those children, because in Idaho, they don't get CHIP either, okay? And so the idea is that it's not only people who are undocumented, but people who are documented and who are the very target of this coverage that are excluded in states like Idaho, okay? Now, I really didn't want to make this presentation because, I don't know, people look at Idaho like como Dios ve a los conejos, chiquitos y orejones. How do you translate that? Right? Like God sees rabbits, little and with big ears. It doesn't translate. But you see, there's some fear in us coming from Idaho, because you say, wow, man, how backward, crucita, Oregon, Washington, progressive, and then Idaho. And so you got to be careful with that, because we have to look at it as being wide open, or else we don't serve the needs of our community. Because if we see it as nothing's going to happen, and this is a mess, and this isn't going to work, then those of us at the community level fail. We fail, because that's not what people are looking. They're not looking for a program from us, okay? It's about the people. All of you know it's about the people. And so that's why it hurts me to stand up and say that the human suffering that is occurring in states like Idaho, because families that are blended can't enroll, because they simply can't. The way the application is set up is you can't get past that. And so the human suffering is really the message that I bring to you. It's whatever we need to do. As much as I say there are problems, and as much as I would want to diss a state like Idaho and others who really haven't gotten on board, and they need to get on board, the reality is we need to remain focused. That we need to take something that gives us a beginning and that allows us to build on it. Because it would be so easy for me, and believe me, I feel so frustrated because of my own personal experience, but especially because we speak of suffering not in human terms, but in profits, in lost money and revenue. And really, it's about the people. And so the ACA was passed with the goal of filling gaps in the availability of affordable health coverage. The reality is, in states like mine that didn't expand Medicaid's, millions of adults will not gain coverage. There are some 5 million adults in some states like ours that make less than, I think the estimate is 17 million other people in other states that make more and are enrolled. And so when you see that, you say, there's something wrong with it. Con mucho cariño. With all due respect. But those of us who are at the community level are still trying to make sense of it ourselves so that we can go out and share in our community something that is a good thing. But up to this point, is still very limited. Why did some of those 10 million not? Because of the blended families. Because, you're looking at us just as if we're all the same. As if we fit this Latino, kind of definition, but we don't. And people are willing to sacrifice their own health, their own life, because there are people in their family. It's the cultural value of familismo. And sometimes it helps us make good decisions that keep us healthy, but sometimes our values, and you can't say they're bad, help us make decisions that help us maintain those values that have brought us this far. We got to quit putting people into this battle of values where you have to decide whether you stay with that value that got here, family, which is what brought me here, or that you try to go to get coverage for part of your family because you know it's the right thing for them. Most of the families who are split that way decide not to. And so they're deciding to align themselves with the people who have been with them for all this time and who will never leave them, instead of leaving them and enrolling themselves. And so there are probably a number of other factors, but it's the complexity of what you're trying to roll out to people who have never had coverage in many cases and really don't understand the language. You understand what bilingual is, eh? For a lot of times we kept telling that we wanted our children to be bilingual, but no, we want our children to be biliterate. We don't want them just to speak the language. We want them to be able to use the language across their lives, in school, across the curriculum, because we know that those will be the people that we've truly helped if we can achieve that. I'm afraid that what we're trying to do is we're trying to do the best we can. But the reality is that human suffering, the suffering that never gets talked about in states that aren't moving forward to make sure that people are covered. I don't want to leave you with this image that it's just Idaho, because I think that that's not what I was called to present. But for those of you who live in states like I do, or for those of you who are trying to serve the Latino community in progressive states like Washington and Oregon, that your challenges may be similar to ours, okay? Because there's a disconnect. There's still not those people out there that can make sense, not in layman's term, but in human terms, in terms of what this care really means for me as a family. And so our challenge, I believe, is to really take, maybe what isn't, the ideal, but to try to make sense of it, to try to work with, with the administration, to try to work with clinics and others. By the way, who's supposed to take care of those folks that are undocumented? They're not going to quit coming to hospitals. They're going to continue to get sick. And I don't know, Rogelio, about what you guys are doing here, but I don't know if you can build a capacity that fast to be able to meet that demand. I applaud you for trying to prepare. I applaud all of you for being here and wanting to make this work. I just wanted to give you an example that it isn't going to be easy. What we have undertaken is probably one of the most difficult challenges of our time, to convince people that we have a program that is going to help people, because it really doesn't put people first. Gracias. I hope I didn't offend anyone.
Do I just press enter for the next one?
Yeah, I'll show you here. Where are you? Where you are. So right here. Over and back. This one there.
Great, thank you. Yeah. Well, good afternoon, everyone. My name is Mayra Benavides. As Michael shared, I am the Director of Outreach for Yakima Valley Farmworkers Clinic, and I apologize since I'm a little short here. I also oversee the Need Hope Clinic, which is a Ryan White Center, and we see patients who are living with HIV/AIDS. And so in my discussion, I'm going to be talking about what our organization did to address the Affordable Care Act, and how we also assisted those individuals who primarily a lot of our patients were undocumented and who are also living with HIV and AIDS, and how ACA impacted them. So some of the goals that we went ahead and took on as a challenge within our organization was to really identify and successfully enroll individuals in our community. Yes, we do serve a lot of Latino members in our community, but we also live in a vast majority diverse community. And so our focus was to really be involved in our community and identify, recruit, and connect those individuals with the enrollment process. We know that once people are insured, their access to medical care will be easier, and we know that in long terms that health disparities will be addressed as well. Also within the Affordable Care Act, there's a whole piece of education, as we heard from other folks on the panel. Education was one of the things that we knew months in advance that we needed to do in order to serve our population. We knew that there was a lot of misconceptions of what the Affordable Care Act is. We knew that families were having conversations, that they were sharing false information. We knew that a lot of our families did not know whether they were going to be eligible. And so as an organization, we prepared months in advance, and we participated in everything from community health fairs, radio. We developed brochures. So every time we were out in a community, we were distributing material. We were answering questions. We were basically putting ourselves in a position where people can come to us, ask questions, and feel comfortable. And we know that we're a trusted source in our community. And so we knew that those individuals would feel comfortable coming to us and asking questions because they did not know whether, if one parent was undocumented, whether the family would be eligible or not. And so to us, that was really important that we clarified, that we really identified individuals who would be eligible, and even those who were not, provide additional resources so that way they could be obtaining resources to address their health care needs. So what we did, again, as part of our community assessment early on, is that we developed strategies. We had an outreach and an in-reach strategy. So part of our outreach services that we did was not only did we participate in what a lot of our community health centers, community organizations do, things like health fairs, community events, but we also got on the radio, we were on TV, we had staff who partnered with schools, we had staff who participated in other community agencies, and sat there a couple of days a week and really talked to those individuals who were coming to those agencies and educated them and provided education. And we gave out information. For instance, as part of our outreach efforts, our organization developed a website. So on this website, we had 6 simple questions. People gave us their name, phone number, email, what was the best time for us to contact them. So 2 months prior to open enrollment, we had hundreds of contacts of individuals that through our outreach efforts, people wanted to be connected to the Affordable Care Act. And so a month prior to open enrollment, we went ahead and contacted them, scheduled appointments, and started working from there. We also put up billboards. So our billboards were pretty easy to understand, basically saying, are you confused with the Affordable Care Act? Because we knew all these misconceptions were out in the community. We had a toll-free number and the website. So that's how we did a lot of our outreach, is really putting ourselves out in the community and giving people a source of how they could connect to us. In terms of in-reach, we have a lot of the similar programs like CMAR does. And so we used a lot of our internal programs and developed strategies within those departments to identify their clients and refer them to our outreach department. We received thousands of referrals based on that partnership within our own system. And we knew that a lot of those individuals, whether it was the client or their boyfriend, husband, siblings, family, you can imagine just from those encounters, how many more encounters we received just based on that internal strategy that we developed within our own system. And of course, we had over 56 individuals who were considered in-person assisters. So we had a full force of trained individuals ready to assist our communities and assist them one-on-one on the application process. I have nurses, RNs, who even though they went onto the website and tried to complete the process, as for those of you who either worked with in-person assisters or went onto the application and tried to complete one yourself, there were some things on there that made it a little difficult. So you can imagine a lot of our Latino families who were not used to entering some of that information or just verifying. You know, for those folks who needed to verify who they were, became a challenge. And so our in-person assisters really became critical in helping our clients have a successful enrollment. And of course, we had bilingual, bicultural staff in our organization. We had an individual who is Russian who came from our Spokane site into our Yakima Valley and was available to assist those individuals living in this area with Russian language services. So just the fact that we looked at our community, saw the needs, and we recruited individuals, hired individuals, trained them appropriately, and made them available for our community. So what are the challenges of doing all of this, of implementing the Affordable Care Act in our communities? Well, one of the things, like I previously mentioned, was really clarifying what the Affordable Care Act. There was a lot of misconceptions and this whole undocumented, documented, whether you're lawfully present or not, and just clarifying. We had so many questions, people just assuming that they would not be eligible, which was incorrect. And so going through that process and really educating our families became one of the challenges of really making sure that they understood and going through the process to make sure if they, in fact, they were eligible or not. And also, you can imagine for those individuals who are undocumented and who have HIV, AIDS, and working with state programs and trying to identify how the Affordable Care Act was going to help these individuals. We had a lot of our patients who were very concerned that they were going to lose their access to medication, to treatment, and so forth. And we worked diligently, my staff worked diligently in working with the state programs as well as with private health plans. And so I'll be talking a little bit of how we were able to successfully connect our undocumented patients living with HIV/AIDS to insurance. So some of our successes as an organization, we were able to enroll just in the Yakima Valley, according to the Health Benefits Exchange between October and February, 12,753 patients. The majority of those, as you can tell, were eligible through the Medicaid expansion, and less than 1,000 through the qualified health plan. So can you imagine all those people who initially thought that they wouldn't be eligible through the Medicaid expansion? And when we went through that process and we realized that they were eligible, you can imagine how grateful our families were. And as employees who work with families and we hear the stories, you know, all the stories that have been shared from the panel today, that's why we do what we do, right? At the end of the day, we do what we do because we are literally changing lives. We were actually able to identify a private health plan who did not ask for Social Securities. And through that process, we were able to connect all of our undocumented patients living with HIV/AIDS to a health plan who accepted also third-party payments. So we have the state program who pays their premiums, and all of our undocumented patients living with HIV/AIDS are also insured. And so there's no worry that they're going to miss their medications or that they're not going to have access to medical treatment. So as some of the panel members have stated, what are our next steps? And that's really helping our clients, our patients, navigating the system. Just because we assisted them with the application doesn't mean that we have additional work to do. And so those same individuals are coming back to us. We're connecting them either to our clinic or other community health centers, assisting them with their insurance card, giving them information on the insurance card, anything that we need to do to make sure that they have a positive outcome and that they're connected to the appropriate medical services. Also, supporting those individuals who are just not eligible for health insurance. We have in our community, we have great collaborations. We have people here from Memorial Hospital who provide Tomando Control de Su Salud, which is a chronic disease self-management class. We offer those classes as well. So between our collaborations, we are able to refer patients who are not connected to a clinic or who do not have insurance and give them the opportunity to attend those classes and learn more about their chronic illnesses. And of course, we will continue to work with state programs and private health plans to make sure that this critical population that are living with HIV/AIDS do not get dropped and do not get pushed to the side. So with that, I'd like to say thank you for your time, and I'm available in case you have any questions. Thank you.
So my schedule says at 2:45 we're supposed to have coffee and tea.
Maybe we should go give it time for a conversation.
You want to have time for a short, brief conversation? So why don't we have our panelists come up front, just if you don't mind. Is that okay with everybody? Okay, all right. What a wonderful job these guys did. I tell you. Introduce yourself if you would. We have a microphone here.
Can you hear me?
No.
Okay. My name is Kessie Williams. I'm at the National Institutes of Minority Health and Health Disparities, but I'm going to take my government glasses off. For those who were in the first plenary session, I want you to go to Department of Justice, Office of Women's, hold on, because we were discussing something. I want to let them know real quick, and then I do have a question for the panel. Office on Violence Against Women. So write that down, Office of Women Against Violence. Okay. Mayra, if you could talk about, or we can reintroduce the Regional Health Administration leave. Did he leave? Yeah. Well, just discuss, for those who don't know, your Regional Health Administrator, if you can, and let them know what they can do and services they provide. If the office is still funding the state partnership grant and those states that are part of the WWAMI, how that office can assist on programs, and also expand on your Office of Minority Health Research Center and how that your center, which is totally awesome, can help these community organizations in their programs.
Thank you for your question. So Jesus Reina, I don't know if he's still in the back, but he was in the back. Okay, so he's our regional minority health consultant. So the Department of Health and Human Services is broken up into 10 regions across the country. It's the 10 regions that the federal government is broken up across the country. So we have a regional health administrator, we have a regional director, we have CMS regional office, we have ACF regional offices, and we have an OMH regional person as well, and that's our regional minority health consultant. And as I mentioned earlier, Jesus, there he is walking in. Take a bow, sir. Really is our lead staff in the region, working with the states in Region 10 to identify issues, concerns, and provide the feedback to the central office. I think the regional structure has been very effective under this administration. Prior administrations didn't emphasize the regional structure as much, but now I think we really are dependent on that regional structure again to inform our process moving forward. In particular, on the Affordable Care Act implementation, we've been able to utilize the regional structure to host regional roundtables, regional working groups related to implementation of the Affordable Care Act, because I think it does vary from state to state, and there are unique challenges from state to state, and how do we address that in policies moving forward. The Office of Minority Health has a resource center. It's associated with our communications arm, but really it provides a tremendous amount of resources to community organizations, particularly in technical assistance, everything from assisting folks with grant applications. I think one of the major challenges for small organizations across the country is that they don't have savvy grant writers and therefore never are competitive when it comes to federal funds. Our resource center provides training to smaller organizations that want assistance in grant applications, but as well as capacity building, a variety of issues. And we have a number of staff members that are part of the resource center reaching out to specific minority populations that are generally smaller organizations to assist them in these efforts. You can find that information at minorityhealth.hhs.gov. OMHRC will be launching a new website in the very near future and hope to make it more user-friendly.
Rogelio Riojas from CMAR. Sam, I really feel your pain in Idaho. You know, I went to visit my in-laws up in Texas, in San Antonio, Texas, and they are really feeling the same pain. It's really unfortunate that some of these states did not agree to the Medicaid expansion. So my question to you, Mayra, is this. It seems to me that the federal government, should be able to do a little bit more than what they've done. I know that it's a difficult task. I was wondering whether HHS ever considered, and I don't know whether the law allows you to do that, but HHS ever considered to work with the health plans, that Medicare works with, directly in other states, to contract directly a federal Medicaid program, to take into consideration the fact that some of these states are being so arbitrary, and it really isn't fair, for some citizens in other states to be eligible for Medicaid at 138% of poverty level, and then in states like Idaho, Texas, and all the South, quite frankly, it's 100%. And so there must be some level of discrimination that's going on there that perhaps our courts can look at, so that the federal government, can contract with Medicare plans, because they do, they don't run everything through the state, and it's part of HHS. And so my question to you, has the HHS considered that?
One thing that you should keep in mind is the Medicaid program is a state-federal partnership, right? So it has to be the state contributing as well as the federal government, and it varies. The state share varies across the board. But for the expansion population, not a penny is paid for by the state. Everything is paid for by the federal government for the first 3 years. For the next 10, everything up to 90% is paid for by the federal government. So it's really not a question of economics when it comes to the Medicaid expansion. And that should really infuriate people across the board, and really where the focus should be, because it's frustrating when we talk to community members and we hold enrollment summits and people wait in line, and then when you come in to get them enrolled, we say you can't because your state has decided not to expand Medicaid. And the opportunity is taken away from them, not because the Affordable Care Act didn't try, but because there was a political decision made by their leadership. And that's unfair and unjust. I will tell you that we have been incredibly creative with states that politically did not want to expand Medicaid by giving them options to expand private coverage under Medicaid. So when it comes to, folks across the political spectrum, their creativity is welcomed by the Department of Health and Human Services. And they can decide to expand their Medicaid program at any point. But what the frustrating part is, even when Republican governors have come forward to say we want to expand, their state legislatures have stopped them. So it really highlights a little bit of the conversation that the speaker this morning spoke about civic engagement and public education and empowerment. And the fact that it's not just a federal government issue, it's a state government issue, it's a local government issue, and it underscores the importance of engaging the Latino community in these political discussions.
Thank you. Other questions? Oh, come on. When something is bound to come to your mind. Oh, Sergio, yes.
I have a comment. That is what you presented, Maria, about all the work that you are trying to do to look for ways to cover the undocumented.
For people living with HIV/AIDS, yes.
Exactly. Yeah. We are doing something similar that goes beyond HIV in California. Actually, I think compared to what the incredible, discussion or comments that you provided us, Sam, California has a lot of good things going for it. The governor supports, finding ways to provide a coverage for undocumented. The Senate, the Assembly, there are bills right now that are working towards that. Associations are working towards that. But still, the public, it is something that we are struggling with. From academic health centers, it is kind of ethically and morally and just a part of the social contract something that that is giving us pause to some of us. You know, that especially I come from the University of California. It's a public institution. It's a land grant institution, and we have an obligation, I think, to serve the public, those who are in need, and yet it hasn't caught up. You know, it is there is a lot of hesitation, quite frankly, on how to go about covering the people that, regardless, that needs to be covered. And when you look at the data that we have with respect to what the undocumented, you know, contributes with the economy, you know, paying taxes but not receiving equally, you know, the services, it is incredibly unfair, you know, from my perspective. And I'm looking this from a public health perspective. I think that is the right thing to do. So I don't know where you are here in Washington. Here we are, you know, in the eve of officially launching the Latino Health Center. I don't know where are you in this conversation, you know, for the University of Washington, you know, to have a position about this, but other you know, it is not only the one represented here. There are others coming from other universities. If you can comment briefly about that, you know, I know there is a big thing, but I think that we need to tackle that in a very serious manner.
I think individually I can definitely take a stand, and I can, you know, activate or not activate, but really encourage others to take a stand and really address this issue, because I am representing my clinic. I want to stay neutral about that. But personally, I agree with you. I think that it is our responsibility, especially Latinos. I come from a migrant farm worker family. My parents have faced a lot of the issues that have been discussed today. And so personally, I do have that challenge to do. But, you know, it's something that we all, as a group, whether we're Latinos or non-Latinos, we have to come together and address those issues.
Just real briefly, you know, if you look at it, you know, from you know, look at it just, you know, from a research perspective. I'm a community-based partner for you. You want me to partner up with you. When I go out and I engage that community, I'm creating expectations when I knock on that door that I'm going to come back as a community organization and do something about the question I'm asking you, or I'm disingenuous, okay, in my asking. They will quit responding to your research questions if what they get is nothing in return. So it's a high stakes for those of you who are doing, you know, from the academic side research, to understand that your community partner cannot go out there and say, listen, it's a quirk in the system. It's your governor. It's, you know, I wished it worked for us, but it simply doesn't. So you got to help us. I don't know how I can tell you, you got to help us, because folks will quit answering your questions. You have an expectation there. And so we can't continue to create an expectation, and then for half of those people, we don't deliver. So do we survey the needs of undocumented people in this country? Do we? Do we research it? Do we do research? Yes, but we do something with the research? That's the question that we have to answer. Are you going to do something with the research? So again, it's a question that I'm putting out there, and you know, yeah, it's the human suffering. I'm going to lead with that first. But if you want to do the academic, you won't be able to do research if you don't have the community-based organization that has any credibility out there, because we have to deliver. So
I just want to follow up on that comment real briefly, and just that I think one of the things we should consider as a group here today is the incredible opportunity we have to think about doing truly community-based participatory research around some of these health policy issues here in the Northwest. We have people here from Oregon. We have a lot of people here from Washington State. We have people here from Idaho. What other states? Montana, Alaska. These are very different contexts that are all right here in our backyard. And we all know each other from these various contexts, these various states. We have an opportunity to have a discussion about not only how do we do the academic research, but do it in a way that has results that make a difference.
We say we're not going to harm them.
We say we're not going to harm them, right? But there are always unintended consequences. You know, we have to be very sensitive to that. But we can. I think it's a challenge that I would throw at you today, is to think about how can we, as a group, think about pushing the envelope on this in the Northwest. So that's all I'm going to say. So there's a question in the back.
Yeah, I was wondering if you had any of the panelists had any suggestions about how to include more parts of the community, because I love coming to these events because I get to network with other people who have some of the same ideas that I have, but we're preaching to the choir. Most of the people here already feel that this is important and they want to do some of that. So how do we involve others that are part of the process of providing our Latino communities with health, you know, the Department of Corrections, all different other places that are probably not represented here, the Department of Education or other agencies that need to hear this conversation?
I'd like to try to respond to your question, and I appreciate the question. I think it's a very good question. I think our work today and in this conference is to organize ourselves and understand each other, get to know each other, and as Michael is saying, sort of develop some thinking in this group that we can then carry forward. This is not the end. This is just the beginning. And, you know, when I hear Sam talk about his experience in Idaho, it really makes me wonder, what can we learn in our state, for example, in Washington, that can be helpful to Sam in Idaho? And, you know, I during one of our breakout sessions, I was hearing from somebody else, another colleague in Idaho, similarly feeling isolated, not having resources. Well, you know, one of the things that our center hopefully will do is to facilitate the sharing of resources and collaboration. So, you know, we don't all have to work just in our context, but we can work across contexts, and maybe there's benefits there that can be shared to make things better. It won't solve all the problems, but it might take us to the beginning of working towards solutions. I don't know if the other...
I can say one thing. You know, in our outreach and enrollment efforts over the past 6 months, one thing that we're certain of is we wouldn't have even been as remotely successful as we were. 8 million is a very good first round. Hopefully we'll get better the next round and the next round and the next round until there are, you know, with comprehensive immigration reform, no uninsured in the country. But that was only possible because every department engaged in the opportunity to educate people. So it wasn't just the responsibility of Health and Human Services, but education sent letters to their school administrators and put flyers and put a widget on their website. The Department of Housing and Urban Development, in their Section 8 housing discussions in their voucher program, they were able to educate people about the Affordable Care Act. Transportation used bus signs and used that as an opportunity to educate people about the health insurance marketplace. And I think it really relates back to the social determinants of health discussion, and that all of our issues are really strongly interconnected. And how do we make health advocates out of our urban planners, out of our transportation leaders, so that they can all feel some sort of responsibility when it comes to the health and well-being of the people we serve? So I strongly agree with you that we need champions outside of the space of public health and into these other fields in order to really improve the health and well-being of our communities.
Just a comment on your, thank you, Sam, for what you said, but yes, we know that we collect data on undocumented, and of the 880,000 farm worker families that were served in the nation's 1,200 health centers last year, about 700,000 would have been identified as Latino, and about half would live in mixed status households. I can say that to this group. I'm on a webinar next week that's sponsored by HRSA, and I can't say undocumented. I can't say that they have difficulty accessing the Affordable Care Act insurance because of their status, I can't say anything like that because it's not protocol. And I was told explicitly that that can't be said on a national webinar. I can say it on MCN's national webinar, which will be the day before. So, you know, there's a problem at the top in terms of being honest about what we do know and then being able to use that information. So yes, we have the information, but because CMAR and every other health center in the nation doesn't collect UDS data that shows the relationship between documentation status or the relationship between ethnicity or the relationship between insurance status and health outcomes, we have a lot of we don't knows. And so we're not able to be advocates. And it's really, really, really hard when the biggest health system in the country can't use its information to be advocates for the vulnerable patients that the taxpayers are saying that they're serving. That needs to change.
Thanks,
Sure, yeah. I will tell you, as an official of the U.S. Department of Health and Human Services, I have clearly stated that there are still millions of people that will be left out of opportunities for coverage with passage of the Affordable Care Act.
Right, I can say that. I can't say because of documentation status.
Happy to discuss offline. I think it's a reality that we've definitely recognized. I mean, the president himself has recognized it in his call for comprehensive immigration reform. You know, the Affordable Care Act, DACA policy changes, those are not meant to solve our immigration problem issues. You know, the only solution to that, the solution to families getting broken apart, the solution to people being left out of coverage is comprehensive immigration reform. And the president can't do that alone. The administration can't do that with discretionary policy. We need Congress to act, and we need all of your help in making that possible.
I have and I think there is a need for, I mean, we are very comfortable talking in this group about these issues in terms of access to care, in terms of culturally competent care. But I think, you know, in my experience, when I go around and talk to different parts of the university, for example, it's not that easy a conversation to have. People don't want to acknowledge the issues, or they want, you know, it's just all okay. And it's being solved by the ACA. And there's a lot of work to do. And so I think, you know, I think these comments about needing to speak more outside of our circle is really, really important, and it's a hard thing to do. And so people in leadership positions need to make those conversations happen. How are we going to expand care? Who is suffering? Who's being left out? And how do we bring them in? I think those are important issues that we need to keep bringing up.
Well, thank you. Why don't we break for coffee and tea? Again, a round of applause.